morning, afternoon, or evening to everybody. So, thank you all for being here. I'm very happy to be with all of you today. And today I'm going to talk about one of my favorite topics, and that is guided bone regeneration. And let's go ahead and get right to it. So I think that when we talk about guided bone regeneration, it's really important to look at the literature. And this was a State of the Science in Implant Dentistry conference that was about 15 years ago that I was involved in looking at hard tissue techniques for regeneration of bone to fabricate the ability for us to place implants and have implants be successful long term. And really, one of the things that was very noticeable from this study that long ago, and even today, as you look through the literature, is that the only other procedure that has as much literature and and science behind it, other than guided bone regeneration, is the sinus augmentation procedure. And so these are the two most common procedures that are performed and studied. And obviously, when we think about bone grafting, probably the most common procedure performed is socket augmentation for an extraction socket, but the most studied are the sinus graft and guided bone regeneration. So, when we talk about grafting materials, there are many different materials that we can utilize. And so, I always like to start just with a discussion of that. First, I'm going to talk about the autograft or autogenous bone. And as we all know, we can use either a block graft or a particulate graft from the autogenous source. And depending on which of these techniques you utilize, you're going to have some different types of properties. First of all, the autograft possesses all three properties of healing. We have osteoconduction, where basically it serves as a scaffold for the host material in the patient's own bone to grow and fill in that area in the defect, which is really common to all bone grafting materials. Otherwise, there would be really no point in utilizing a grafting material. Autogenous bone is also osteoinductive, and that means that it brings stem cells to the area where the graft is being done and causes them to differentiate into osteoblasts and form bone. And so this is a property that's very, very important and helpful. But a lot of the time with the types of grafting that we're doing for implant dentistry, we don't always need it. If we're doing a large continuity defect in the maxilla or the mandible or a very large graft, we often do need this type of property. But for the majority of the intraoral bone grafting procedures that we're doing, we may not need that. And then the last property that autogenous bone possesses is osteogenesis. And that is basically when you transplant the bone graft from one area to another, and some of the cells are living and they actually form bone in their new transplanted area. And so, really, the autogenous bone is the only one that can do all of these. Now, of course, autogenous bone is biocompatible because otherwise, a person's own bone is always going to be biocompatible. But of course, there's morbidity associated with any donor site. And so, certainly, due to this morbidity and the limited supply, that's also things that maybe make us not want to always think of doing an autograft if we don't need it. So what else do we have? Well, we have an allograft, and this is from the same species, so a human cadaver. And if we're going to use a particulate, we're either going to have mineralized or demineralized. And both of these have their advantages and disadvantages. The demineralized allograft is utilized sometimes because it contains some BMPs, and so it may possess some very, very minor osteoinductive properties that I just talked about. But the amount of osteoinduction is so little that, really, in my opinion, it doesn't really justify the use of demineralized if that's the reason that you're choosing this type of allograft. My favorite to use when I'm using an allograft is mineralized because of the structure. And so generally, we have bone grafts that are going to be under some type of tension, either from the overlying soft tissue, or maybe there is a bone, like a buccal defect that's missing, the buccal wall is missing. And so, if you don't have mineralized graft, then you're going to have a lot of pressure and compression on that graft, and it can decrease the volume. So, in general, I like to use mineralized. And then, of course, either the particulate or nowadays we have some block grafts as well that are allografts. So these possess definitely the osteoconductive properties. Remember, I said that we have a scaffold that's going to hold and support the soft tissue. The osteoinduction, as I mentioned, is minimal and questionable, and only potentially with the demineralized. So I mostly think of an allograft as an osteoconductive type of graft. We get new bone formation after it resorbs. And, this is one of the things where when you're choosing your bone graft material, you want to choose something that is going to resorb within the time that you're going to go back in and enter to either place your implant, or if you're not going to re enter and you want it to support the tissue, then you may want to keep something that stays around a little bit longer. So with allograft, there's always the question of disease transmission, which is one of the reasons why this is not a universally approved grafting material that can be used throughout the world, because there is always that possibility. Now, of course, these materials are all tested for everything that can possibly be tested, HIV, hepatitis, all kinds of different bacteria, viruses, fungi, and things. But, we never know what could come up in the future that maybe something isn't tested for. In addition, the materials are freeze dried. And so basically, the majority of the organic material is removed. So these are very, very safe materials to use. The other material that is very, very common to use is a xenograft, and this is from a different species. And whether it's going to be a bovine source or a porcine source or even an equine source, these are usually what is utilized. And of course, the most common is the bovine or the cow bone. And so this can be particulate, and there are even now some block grafts for xenograft, but the most common is the particulate graft. And again, the osteoconductive properties are very, very apparent. These materials have similar structure to bone. They integrate very well with the native bone, but one of the sometimes positives and sometimes negatives is that the remodeling and turnover is very low and sometimes even absent. And so this can be difficult if you want to go back into a socket that was grafted or some other kind of defect and place an implant, and you want it to have completely turned over and form new bone. However, when you're trying to support soft tissue, such as a lateral augmentation in the anterior maxilla or throughout the mandible, and you want the material to stay there for a very, very long time, then this is a very positive property. And so, depending on what type of grafting material, then you'll choose based on what your needs are. And then, of course, the thought of disease transmission. And again, this is very rare, and the way that the materials are both screened and processed, it's almost non existent. And then the final materials are alloplasts. And these are basically synthetic materials. And generally, they're going to come particulate. And usually, they're a combination of hydroxyapatite and tricalcium phosphate. And so, of course, these are biocompatible and osteoconductive. And then the ratio figuring out is very challenging. And you can see the TCP is going to resorb quicker, and the HA is going to stay there for quite some time. So I don't quite think that we have figured out what the proper ratio is for this HA TCP type of material. So that's all of them. We have allograft, xenograft, autograft, and alloplast. So let's talk about what the literature shows. And most of the grafting materials these days that have been studied are the xenograft. And so the majority of the studies that are published, that is what you're going to see. And really, when we look at autogenous bone versus xenografts for onlay grafting and for guided bone regeneration, there wasn't any different in implant survival. And so that really called into question around this time, do we need to be using autografts for all of these procedures? And the answer probably is no. Um, Really, again, looking at our different grafting materials. When we think about how to try to start enhancing our bone grafting materials, because even though implant survival is just as high, there are often times when the patient's own bone and their capacity to heal is not going to be ideal. And so by using a material that has to be completely remodeled and turned over and then form new bone is going to be difficult for patients, especially when it's a compromised site or they have significant medical problems. And so we start to think about, can we use some of these adjunctive materials to try to improve that? And really, at this point of the study, and even really now, there's not been a significant improvement by adding any of these enhancers, so to speak, whether it's platelet rich plasma or PRF or other growth factors. We really, really haven't seen a significant improvement in implant survival or success when these are combined for grafting. And so really, we're still in the infancy of trying to add these type of adjuncts, but of course they are being done quite a bit, and I'm going to show you, I think I have one case in here to discuss that today. So, does GBR work? And that's the question. And obviously, the answer is yes, or we wouldn't be discussing it and there wouldn't be as many studies as there are today. And when we're thinking about GBR, we can either do it before the implants are placed or at the time of implant placement. And, it can be done as a particulate, like I mentioned, a block graft, or splitting the ridge and placing the grafting material inside. And that's a bit less common. On average, we can get, a little over 4 millimeters of width, and when I'm talking about GBR, I'm mostly talking about width of bone. That's something, again, that we have to discuss separately. And I think that all of us out there that do bone grafting know that the vertical augmentation is very, very challenging, and it's not at all the same as horizontal augmentation. And so the horizontal GBR is really the much more predictable procedure. If we're using an autogenous block, we can do that. Otherwise, we're going to use a membrane with a particulate grafting material. And of course, if you use a particulate graft, you're going to have vascularization that's faster. You're going to have consolidation that's faster, and you can use it with all of these materials and in combination. So a lot of times, what clinicians are doing today is they're combining because they want some of the properties of something that resorbs a little bit faster. They want some of the osteogenic or osteoinductive properties that autogenous bone gives. And then they want some of the properties that of a material that stays around longer. And so clearly, if we're combining all of these materials, we still have not found the perfect grafting material. And I'm always hopeful that in my practice lifetime, or maybe in my actual living lifetime, that we will get a perfect bone grafting material. But something certainly that that we're always in search of as clinicians to try to prepare for our patients. So let's talk about an autogenous block. And this is a case you can see we have a very thin maxilla in the premolar and canine region. And so this is really the treatment that we would always do before. When I was a resident, the number of ramus block grafts that I did was quite high. And so you can see that usually we outline the area that's going to be taken, use either a small Fisher burr or a piezo or a saw or whatever it is that people like to use, remove that, obviously staying away from the inferior alveolar nerve. It really was abandoned pretty early where chin block grafts were not done because if patients had teeth in the anterior mandible, they were developing numbness in the teeth. And so, unless someone was a dentulous, I really never did a chin block graft, almost always from the ramus. And you can see that we can screw and fixate that in. And we all know from the principles of fixation that we generally are going to need two screws at least to stabilize so that the graft isn't spinning around. If you have a mobile graft, it's really not going to heal very well to the site. And then, of course, we could pack it around with a particulate of whatever type of graft material you like to use, and then we would close it up after we re-enter. And this was at 4 months. And so one of the things that we know with an autogenous bone graft is that after 4 months, you can enter very quickly. You can place the implants, and then that's going to be very nicely healed. You can see that we have an increase in the width, and then we can uncover the implants. If we have to do a soft tissue grafting procedure, then obviously that's done at the same time or at a later time. And then we have our final restoration after about a period of 6 months. And so certainly we can get a very nice result with that. But of course, we have the morbidity and we have quite a bit of time that goes by. And so, can we do something a little bit differently? Can we use a material that's not autogenous to save this patient this type of donor site? And so we know that a membrane, if we use a membrane, a particulate graft, it has to have a membrane to be able to contain it very well. And so this is a case where the patient is missing both central incisors in the maxilla. We're missing that central papilla, which is very, very challenging to regenerate. And so we can see that we have quite a bit of a width defect. We have plenty of height, but not enough width. And this is generally not a problem. When I see that there isn't enough height, that's when I get a bit concerned. Nowadays, we have shorter implants that does give us more options. But if we're looking in an area such as the anterior maxilla, then it's great if we have enough height. But here we're deficient in width. And so you can see when we flap the area that we have these concavities here because the teeth have been missing for quite some time. We have good bone on the lateral incisors here. And so we know that we're going to be able to do our implants and our graft at the same time. And this is obviously something that you want to discuss and go over with the patient and look at the CT scans and have all of that discussion. one of the things is that even if you were to do the guided bone regeneration procedure first and then come back to do implants later, I always tell the patients there might be a possibility that we have to do a little bit more grafting later on, especially when we're in the anterior maxilla. You never really want to get caught where you tell the patient that they're not going to need any more grafting and then all of a sudden you have to do more. It's always better to kind of oversell and over prepare the patients to have a little bit more grafting done. And then if you don't have to do it, they're going to know it's because you're so good and you did such a great job that that's why you don't have to do more grafting. So keeping that in mind to really never underplay it, but always overplay it just a little. And then you can decide if I have a patient who's already paid for a GBR procedure, if I have to add a little bit more bone, I don't charge them again because the patients hate to be really getting charged really at every stage. And so if you have the plan and you've already done that and they've already paid, if you have to do a little more bone grafting, no big deal. Okay. So that's the approach that I take so that patients don't feel like they're being taken for extra money that they didn't know about. And so you can see we place our implants. We want to have a nice distance between to help to um, allow space for the bone to be maintained and have a nice papilla. And you can see that even though we don't have a dehiscence, we have very, very thin bone. And we know from the literature that we need at least 2 millimeters on the buccal and really even 3 millimeters in the anterior maxilla. And so then you can see this is our particulate graft. You can see this is our membrane here that's going to go over the defect, and then we're going to primarily close. And so you can see here this primary closure, this is after about a week. And so really, and I'll talk about this later, but the most important thing when you're doing any kind of guided bone regeneration procedure is the primary closure. And there are a lot of techniques out there that discuss using specific membranes or other techniques where you don't have to have primary closure, and I always still strive for it even if the wound opens. Of course, having some materials that are a little bit more robust and can handle being exposed would be great, but I never really use that to substitute for good surgical technique. But obviously, since today is complications, I'm going to show you some cases where that didn't happen. And so this is our final restoration. And, if I were to be a little critical, I don't restore implants myself, but I would say that, we all know that we want to have a lot of under contouring in the gingival margin, and we certainly want to open up that embrasure. And, the mistake, I think, the inclination is to try to fill up any holes or gaps with material. So whether it's going to be pink material or it's going to be making the teeth wider and the longer contact points, the tendency is to really do that rather than have a patient in a temporary with this area open to hopefully allow as much as you can to let the tissue go and grow into that area. And so, if I were to do this case again, I would have the patient in a temporary and have this very, very open. And then later on, we can always fix it and close it up if the tissue doesn't fill in, or if we decide not to do a soft tissue graft. So this was without a soft tissue graft, and that's another question. Should we always be doing soft tissue grafts? And that's a discussion that I have a lot with patients. And when it's in the anterior maxilla, I tell them that we're pretty much always going to need to do a soft tissue graft. And then if we don't, then again, you're the hero because you did such a good job that you don't need to do a graft. Okay, and then you can see the implants in place. And this is after 5 years. And so what about membranes? And we all know that the principles of GBR or even guided tissue regeneration of any kind is to block out unwanted tissue and allow time for the tissue that we're wanting to form in there. And so obviously we all know that soft tissue heals much faster than bone, so we need to block out the soft tissue and allow for the bone to heal. And so the membranes do exactly that. They're going to stabilize the wound, they're going to create space, they're going to exclude the soft tissue, they're going to have space maintenance, and of course, they're biocompatible. And so they're going to generally be collagen type membranes, cross-linked if we need them to have, if they're going to be working in a larger defect or we want them to stay around longer. Sometimes we're going to use non-resorbable membranes. Non-resorbable membranes are not my favorite, and I'll tell you why in a few minutes. I don't like the idea of having to remove a membrane, and definitely the complication rate is quite high with them, and I'll talk about that in a second. And then, membranes have been shown to regenerate lots of areas of bone. For example, there have been some very nice studies that have looked at if you're doing a lateral window sinus augmentation approach, if you don't put a membrane over the window, you don't get as good of bone formation as if you put a collagen membrane over the window. And so, really, when we're thinking about GBR, when we want to block out the soft tissue and we want things to heal very nicely, then we want to use a collagen occlusive membrane. Now, when I say membranes, I'm talking about occlusive membranes. I'm not talking about like a PRF or a PRP membrane. Those are not occlusive. Those are only going to stay at most for a couple of weeks. And so that's not enough time to allow for the bone to heal and form in there. So if you're buying a PRF machine and thinking that you're going to omit your need for use of collagen occlusive membranes, then that's not going to happen because you still are going to need an occlusive membrane. So this is a case where I'm going to remove the incisors and do a guided bone regeneration procedure and a socket graft at the same time. And so this can be a little bit challenging because this is very, very thin tissue. She is a female patient of very thin stature with very thin tissue, as you can see, and she's 70 years old at the time we did this procedure. And so certainly I know that the tissues are going to be very friable and thin. And so I'm a little bit concerned about the extractions and being able to actually mobilize the gingiva to completely cover the extraction sockets. And so you can see the teeth have been removed, and now we have the membrane that I'm fitting. And with membranes, less is usually more. You don't want the membranes to cover over the teeth and get in an area where they can become exposed. And again, like I said, I'm not quite sure that I'm going to be able to completely cover all of the extraction sockets. And so I'm going to use a socket augmentation material, the Ossix bone, where if it is visualized and left open a little bit, then I'm not concerned, especially in the socket graft. In the area where I'm doing the GBR, then that is a concern, which is why I'm using the collagen membrane. And this is an Ossix membrane here. And so you can see here, I like to pre-cut with a really sharp blade my Ossix bone when I'm using it so that it's going to fit right into the defect. And so this is the bone into the socket graft. You can see my incision here, and this is the area where the guided bone regeneration has to take place. And I've already, before I get my bone graft in place and everything, you can see the membranes folded back here nicely. It's already cut and fit to place. I've already released my periosteum so that I can get primary closure as well as possible. And then you can see this is after the bone graft is in, the guided bone regeneration is in, and we have our membrane covering. And then this is the closure. And again, when you're going to close a large area and have a bit of guided bone regeneration, I want my flap to be larger with vertical releases away from the incision. And actually, I was able to mobilize this pretty well. And so I did do primary closure. And you can see here, I like to use a mattress suture. So I have some horizontal mattress sutures here with 5-0 Vicryl. And then after that, I have some 5-0 chromic gut suture to oversew that. People may use sutures that are non-resorbable here, and that's completely fine and up to you. I don't recommend that you use silk sutures because those really wick and they're braided, and so they're a really great plaque and bacteria trap. So if you're going to use something that's non-resorbable, either nylon or Prolene, or of course PTFE sutures if you like. But I generally try to avoid using non-resorbable because I don't want to have to take out the sutures on the patients. And so again, it's a personal choice, but most of the time I'm using Vicryl in the ones that I want to stay around a bit longer. And then this is the patient after she heals, and you can see we have really, really nice soft tissue. This is after about 4 weeks, and you can see we have a good keratinized tissue, which I was a little bit worried about. Sometimes when you release a flap and then bring the mucosa up over the crest of the ridge, you may compromise your attached tissue, and so that is doing very well here. If that happens, of course, you can always make your incision right on the crest when you place the implants and push that to the buccal, which is what I'm about to do. So I'm scheduled to see her in about a week or two to do the implant surgery. And so you can see here we have nice keratinized tissue. The implants are going to be in the lateral incisor position for a fixed partial denture on those 2 implants. So a very nice bed in this area here.
So this is another patient that I did 2 implants for an overdenture in the mandible about 10 years ago, and she's been wearing a denture ever since. You can see that her mucosa is pretty friable, and it's been really difficult for her to maintain, and she started to have a lot of mucosal type of symptoms. And so now she wants to have an implant-assisted removable partial denture. So we're going to do some implants. You can see that we have our panoramic and our CT scan, and of course the bone is very thin because she's about a 75-year-old patient, and she's been missing her maxillary teeth for about 25 or 30 years, so quite a long time. And so I discussed with the patient, and I made the decision that I was going to do the guided bone regeneration first, and then we were going to do the implant secondary. But if we need to graft a little bit more at the time of the implant placement, then obviously that would be done if need be. So you can see here, I was using PRF so that I have a very nice particulate, but very, very secured aspect of bone. So you can see this is the sticky bone made here with PRF. And then this is again the collagen membrane. This is an Ossix membrane that is, I like to use the membrane. In this case, I use this membrane because once it gets wet and I actually put the PRF on it as a liquid, it gets kind of like the consistency of a wet paper towel. And so I don't need it to hold a lot of structure. I just really want it to sit very nicely under the tissues. I don't want to have to fixate it in this case because her tissue is very thin. So I was concerned about if I needed to use any tacks that they might perforate through the mucosa. And so with this membrane, you don't need to use any tacks at all. And so you can see it here. It's being placed, it's tucked under the lingual tissue. You can use some periosteal sutures if you want to hold it down, but it tucked in very, very nicely. And then I was able to close the area primarily very well. And so this is her. And we'll talk about prostheses to use in the interim a bit here. I think that when you're doing a GBR, if you have a removable prosthesis on it, especially initially, it can be very detrimental. And so really thinking about that, considering the options and talking to your patients about how they're going to maintain a provisional prosthesis is really important. I have actually found that during this quarantine last year, a lot of patients were much more willing to go without wearing their prosthesis in the provisional time because they were wearing masks all the time and only seeing their family. So this has been really great for the GBR procedure, I have to say. So I've been very, very happy with how the patients have responded during this time without wearing a prosthesis on it. This is the patient after she's healed. You can see again, her tissues are not perfect and not ideal. And so any hardware that we can avoid would be a good idea. And so you can see here, this is when I re-entered, able to place implants without any problems. Very nice bone. There are some remnants of the membrane, which is okay. Everything is healed super nicely. And then this is her after. You can see we have really nice tissue and smile line. This is the bar that was made for her prosthesis. You can see that we have really, really great tissue all around it, and she is able to maintain very well. She probably needs to do a little bit better cleaning under the bar around this area here, but around the implant, she's doing a very good job. And you can see here, nice tissue surrounding, and no soft tissue graft was done at all, just the bone graft. So let's talk about different types of membranes. And as I mentioned, we have titanium reinforced membranes and we have titanium mesh, and I'm going to talk about those. And obviously, the ones that are titanium reinforced or mesh are going to have a very high strength and stiffness. They're going to definitely hold the space and maintain volume. They can be pre-bent or pre-made because sometimes these can be very challenging to do at the time you're doing the procedure. This is usually at the time where you've already done a good amount of the procedure and you don't want to spend a lot of time fiddling with that, especially if you have the patient under anesthesia. So the 3D printed or pre-bent or pre-made are very, very convenient. If they're non-resorbable, of course, they must be removed, and that can be difficult because sometimes when you want to go back in to place your implants, your incision isn't going to be as large as it was for the GBR procedure. And this is one of the reasons that I don't really like using a membrane that I have to remove later. And then, of course, we have either the polytetrafluoric
membrane, the PTFE membranes, or we have the titanium mesh. And so those are both options. And then we have the ePTFE, the expanded polytetrafluoroethylene membrane that has an occlusive function at the coronal border. And these are the ones that potentially can be exposed and it's okay and it's not going to cause any problems. But again, most membranes really do better if they are going to stay and remain closed. So this is a patient of mine that I'll show you in a little bit, and this is a PTFE membrane that has become exposed and it's infected. And so, the question is always, what do you do? Because the number and the percentage of these membranes that gets infected is very, very high. It's, upwards of 30% or so. So again, really, really challenging and how we manage that if that happens. And then of course, titanium mesh, you can see that it holds space and does very well. But at the same time, you have to completely make a much larger flap at the time so that you can remove the whole thing. And again, that becomes very, very difficult to do in certain cases. Good rigidity, excellent stabilization, but can be mechanically irritating. And I'll show you this case in a minute too. So what is the success rates of implants in regenerated bone? Because of course we don't do GBR just for the sake of GBR. It's so that we can do implants, whether it's simultaneously placed or whether it's delayed placement. We want the implants to survive, to be successful and be successful long term and have good function and aesthetics. And so that's really, really the purpose. And so when we look at studies, we can look at studies with autograft. You can see that we have a pretty wide range of success. And the difficulty with GBR and trying to figure out the success rate with implants is that GBR can be something as simple as a few granules of our particulate graft material that's done at the same time as an implant is placed, or a much larger procedure like I showed you in the previous couple of cases. And so really, those don't always get separated out in terms of figuring out what the success rate of implants is. And so that's why the range is so varied. And so this is a review that looked at 13 studies showing a very, very high success rate of implants, 96.8 to 100%, and lateral ridge augmentation, both staged and simultaneous, with very high success rates in 2015 that were published. And then again, looking at block grafts, autogenous, 98%, and lateral ridge augmentation, again, with various materials, 97 to 100%. So how do we choose? Basically, what I think this is showing is that all the different techniques and all the different materials can have very, very high success and can provide the foundation for good, long-term, stable implants. It just really depends on what exactly you're trying to do, your area of expertise, and how you manage the tissues. And so I think that those are really the most important things, and I'll talk about those as we go along. So I think one other thing to think about is also the risk factors of the procedure and the patient before you get started. And identifying these beforehand is important when you're selecting both your technique and your materials. So for example, we want to look at the patient's risk, and systemic risk is always important. Does the patient have diabetes? Do they have osteoporosis? Have they had chemotherapy or radiation, or even more commonly these days, an anti-resorptive for osteoporosis? Or have they had some kind of immunomodulator medication for psoriasis or rheumatoid arthritis or lupus or any of these diseases that are becoming more and more common? And so really identifying that and thinking, how is that going to affect both my bone and soft tissue healing? And how is that going to affect the quality of the tissue as well? Do they have any habits? Are they smoking? Are they vaping? Are they using marijuana? Are they drinking alcohol? And if they are, certainly we know that with implants, we have a higher failure rate, but we definitely have a much higher failure rate and biologic complications with bone grafting and with soft tissue grafting. And so even if you might tolerate a little bit of smoking or some alcohol use when you're doing just a simple implant procedure, when you're doing a GBR, a larger bone grafting procedure, these are really the times when they need to absolutely stop. And so I'm very demanding about if I'm going to do a bone graft or a soft tissue graft and the patient's habits and that their systemic conditions are under the best possible control. I have a couple of diabetic patients right now that need a bone graft before an implant, and I'm absolutely not doing them until their diabetes is under better control, because I certainly don't want it to get infected. We have enough complications even when all of the conditions are right, but if you start with conditions that are not right, then you're really opening yourself up for failures. And while we might get lucky cavity, because the oral cavity is very forgiving and the healing is good, and in general, the vascularity is good. It's really important for the patient to make that commitment to him or herself that they're going to do everything they can to ensure that the procedure is successful. Because if a procedure fails and you didn't really stress or determine that some of their medical or social habits could have an effect, then they're going to think it's all you and your technique, and they're going to want you to redo everything for free, and they're going to blame you. And when patients have spent a lot of money on these procedures, it happens a lot. And so certainly by bringing all of these things up, even if they say, the guy or the girl down the street doesn't have a problem with my diabetes and they said it's fine, and so I'm going to go to him or her, they should go, because once there's a problem, they're going to come back to you, and then you're going to be asked to fix it. So certainly whenever you don't feel comfortable with a patient committing and taking care of their own medical conditions, then I think it's better that that patient go away, to be honest. Patient local risk factors. Have there been multiple failures of, failed endo, periodontal surgery, apicoectomies, extractions that were traumatic, and now we're left with either a minimal soft tissue envelope or teeth that have had infections there in the past, or a lot of scarring. And so I think that pointing these things out are really important. Is the soft tissue biotype good? Are you confident that you're going to be able to get primary closure over this wound? Or are you worried that it's going to break down? Because the breakdown is really a killer of your bone graft. What is the periodontal health of the rest of the mouth? I mean, we certainly don't want to restore implants in the posterior mandible when we have, a tremendous infection in the anterior maxilla. So again, making sure that in general they're in good health and that their teeth are in good shape. And then of course their hygiene, because we all know from discussing periimplantitis and other complications that if a patient doesn't have good oral hygiene with their native teeth, then it's only going to be that much more difficult when we're talking about implant maintenance. And then of course surgical risk. Do we have enough bone, both quality and quantity? Are we going to be able to get primary wound closure without tension? And then the restorative risk. And I think this is so, so important. And I don't think it's discussed enough. What are we going to do for a prosthesis temporarily? And I think that the best type of prosthesis you can use temporarily is one that's tooth-borne, if possible, on adjacent teeth and completely is relieved of any pressure. And if someone's going to have to wear some kind of flipper or a denture, I want them to have at least 2 weeks without using it, because otherwise a large amount of pressure on your bone graft is just going to melt it away, cause mobility, cause it to open and dehiss. And so, if the patient can't commit to that, then I'm not so sure that I want to embark on this large procedure. Okay. I have a patient right now that I don't have in here, but that has a very large defect and has some teeth on either side that are going to be extracted later. But while I was doing the bone graft, she has a fixed prosthesis on those teeth that are going to be extracted later, so that it doesn't put any pressure on the bone graft while healing. So certainly thinking about that temporary prosthesis is really, really important, and making sure that you can commit to that. So let's talk about complications, both short-term and long-term, membrane exposure and infection, and then again later implant dehiscence, bone graft failure, and complete implant failure. And so all of these can definitely happen and will happen, especially if you do a lot of cases. And so it starts with choosing the right patient and then with your technique. And sometimes, like I said, even if you do everything right, still these are going to potentially happen. So let's talk about short term first. And so this is a patient with a failing implant and non-restorable anterior mandibular teeth, and she's going to have extractions of the teeth and the implant removal and simultaneous GBR. And you can see here that we have an implant that's in place, that it has some periimplantitis that's developed over time. This was an implant that was placed very, very deep. You can see that there is some bone loss initially and even more bone loss now. And the inflammation has really traveled all the way around to the adjacent teeth. So now the teeth are going to need to be extracted as well. So this is the situation when it's open, the teeth are removed. You can see this inflammation all around, significant granulation tissue, and we have a very large defect. And so in this case, a graft was performed with a non-resorbable membrane just because of the large defect. Now, in retrospect, that's something that I probably would have rethought. And the reason I would have rethought that is because the quality of the tissue in an inflamed and infected site was already compromised. And we know that the anterior mandibular gingiva is very thin as well. And so to really think that that tissue is going to be able to hold up and stand up to the test of time was probably a little bit naive, I have to say. And so you can see once everything is removed, we have quite a large defect. We're missing a lot of the buccal wall. And so a graft was done, and this is an alloplast at the time. The patient did not want to have either a xenograft or an allograft. And, these days you're going to get patients that are going to be a little bit more particular about what grafting material is used. And so that's a separate discussion that maybe we didn't have to have as much in the past with our patients, but now is really, really important to make sure that they know exactly what material they're getting, and they're both, ethically and religiously okay with whatever type of tissue you're giving them. And you can see we got a nice primary closure. However, you can see that the quality of this tissue is not good. It's boggy, it's cyanotic. It really, again, we have the mattress sutures as well as the oversewn area, but really, really not good quality tissue. And so this might have been a case that to remove everything first, clean up the inflammation, and then go in to do the bone graft. But then you know that if you're going to do that, then you're going to have a more vertical problem as well. And so you can see here that even though a lot of it healed, superiorly we had a dehiscence down more in the vestibule. And this is where the membrane got exposed. And like I said, it's a tremendous plaque and bacteria trap once you get the membrane exposed in that area. And so now what do we do? So the answer really depends on if it was a late exposure or an early exposure. If it's exposed early, you're kind of stuck because you're going to lose a lot of your graft. And if you possibly can, we want to try to maintain and keep it clean. If it's not infected, at least you're going to be able to nurse it along until the bone graft underneath heals. But if it's infected and you can't control it, then you're going to have to remove it. Now, some people might say, well, why don't you go back in and try to suture it? When the tissue is very friable, really in the first couple of weeks, there's almost no way that you're going to be able to suture that closed because it's going to reopen again. And until everything's matured, if you go in and open this up and try to suture it here, then you're going to pull on this tissue. And so really, we maintained this for a little while, cleaned it up. I usually recommend on the end of a cotton swab, Paradex, and really scrub that area to make sure you get all the plaque and bacteria off. And the better that they can maintain that, then the better that's going to be. So you can see once the membrane's removed, it's really a junky, infected, inflamed area. We kept it as long as we could. I think we kept it for about a month and a half or two after it had exposed. And then we need to go back in. You can see that we have an opening defect here. So if this was not all revascularized and healed, then we might actually lose this whole entire piece. And so that was really one of the main reasons that I wanted to wait so that we could get good healing and vascularization. And so this area could be saved. And so we are going to go in and clean the membrane out and clean everything out. And you can see here that we actually have some decent amount of bone that's formed. And, if you can nurse that along, then that will often happen. We know that we're not going to get complete success of the graft, but to try to salvage as much as possible. And then this is a case where a PRF membrane was used to help with soft tissue healing. We closed that defect more at the inferior aspect in the mucosa, and then a PRF membrane. And we're not doing any other grafting at this time, just removing the membrane and letting it heal. And you can see here that it goes on to heal very nicely. This is after about another 3 months. And so then we're going to be able to go in now and do our implants. So not a perfect result, but definitely much improved. And we have good amount of bone that we can place our implants into. So this is another patient with anterior teeth that we're missing. She's very, very particular and wants a perfect result. And she's going to have implants in the lateral maxillary incisors, and then she's going to have a fixed anterior bridge. And so this is what her temporary is. She's been missing all of these teeth, and she has a temporary on her canine teeth. You can see here that there's a lot of volume missing in the horizontal dimension. You can see her CT scan, a very, very thin amount of bone. So this is a adequate height, but definitely very thin width. And so we're going to make a large incision. You can see that we made some little grooves to try to help stimulate some vascularity from underneath. And if a bone is very, very cortical and there's not a lot of vascularity, then it's generally a good idea to make either some grooves to decorticate or make some vascular channels to really help the vasculature come through and help the integration of the graft to the recipient site. And you can see here, this is an area where a titanium mesh was used, and you can see that it can be very, very rigid and really support the soft tissue. It has to be fixated, obviously. And then the patient's going to be wearing her fixed temporary on the teeth, which is a great way to keep the pressure off again. This is after about 6 months when we're ready to go in. And one thing that you can see is that even though she had good thick tissues, the mesh is really starting to show through in this area here. So it's almost exposed. And so really, really a potential problem that happens with the mesh, whether it's a screw here or it's a sharp area of the mesh, or even if everything's lying down flat, that mesh can be very, very irritating. And you can imagine if there was a prosthesis on top of this, it definitely would have exposed. And so you can see we have very nice contours. And you can see that we have good thickness as well. And so now we're going to go in, and the problem, like I said, with the mesh is that we have to remove the mesh. And so, there are different ways to remove it. I think probably the easiest way is to cut it down the middle right at the occlusal and then pull it out from the buccal and pull it out from the palatal after removing the screws, of course. And, again, depending on how integrated in the bone the mesh is, if there was a little part up here that was really stuck in the bone, I would just leave it. If it's going to cause more harm to remove it, then to take it, then to leave it in place, then we could just leave it in place. Okay. And if it ever bothers the patient later, you could always make a remote incision up here at the vestibule, and you could take it out that way if we needed to. Okay. But in this case, the tissue was very thin overlying, and it was already putting quite a bit of pressure, and it was not difficult to remove. So I just removed the whole thing. And you can see here we have some very, very nice bone. We're able to put our implants in the lateral incisor position. And then she has her final restoration. You can see here as well, her final restoration. And so she did very well, and she was very happy. This is again another time where I think that this could have been opened up more with provisionals to allow the tissue to come down into the area and form and heal very well. And then, of course, because patients will always come back and see you if they have a problem. She went on about 5 years later. I saw her, and unfortunately, she had to get a new prosthesis and had quite a bit of resorption. And so you can see here, not an aesthetic result at all. And so this is a significant complication of the procedure. And, whether definitely you could see that the maximum amount of grafting was done at the time, but perhaps a material that would not resorb would have been better to use so that it would hold and maintain the contours. Okay. So again, and thing that when you look at patients long term, it's very easy to say that the implants have survived and you're going to get a good short-term aesthetic result, but when you look at them long term, you often don't end up with exactly what you're expecting. And so we certainly have a problem here. And while I think that this could be improved with the prosthetic material here, she has a high smile line, and that's certainly a problem. So let's look at this next patient. This is a patient who is 21 and has been missing a canine and lateral incisor for a very long time because she had an impacted canine that was not able to be brought in orthodontically, and it left a very, very large defect. I didn't see her then, but she presented when she was ready at an appropriate age for implants. And so you can see this is what she's been wearing. She's a very, very attractive girl, and she's wearing this awful partial with a lot of acrylic on it, and she doesn't have something that's fixed. And so she was really wanting to have a fixed restoration with implants. And so you can see this is the defect. We have a pretty significant defect, and our space is also a little bit compromised, and she's not willing to go through orthodontics again because she had quite a bit of ortho when she was younger. So this is a particulate graft that is done. You can see we have a large incision because we don't want to have any tension on the wound. And again, because of the size of the defect, I used a titanium reinforced membrane. And I have to say that the majority of complications that I've had with this, not all, but the majority have been with the titanium reinforced or mesh. And so you can see our particulate graft that was some autogenous bone mixed with a xenograft in this case. You can see this is a titanium reinforced membrane. And so obviously it can really, really withstand the pressure of any soft tissue and hold its shape very well. You can see it's tacked down nicely so that it's stable and closed. And this is after healing. This is after about 3 or 4 weeks healing, and she did very, very well. The problem was that she disappeared for quite some time after. You know, life gets busy, as you know, and she lived about an hour away, and so didn't come in for about 3 more months. And you know that was obviously a significant problem. So we have good closure. We didn't necessarily get a lot of the vertical defect regenerated, but I knew that we weren't going to be able to do that. I really wanted to have enough horizontal bone to get the implants, and so we knew that the vertical defect was still going to be there. And so you can see that when she returned, we started to have an infection. So this was a late infection. The membrane exposed, and you can see here that she went for quite some time with this as is. And when there's an infection, the quality of the tissue is not very good. And so you can see that obviously we're going to have to remove this membrane. But it had been in now, it was about 4 to 5 months. And so I was comfortable with the healing of the graft and that we were going to take it out. So you can see here, once I entered, it was a membrane that had a lot of plaque and bacteria attached, but that's really just on the surface. And so the rest of the membrane had done very well. And when you take it off, you can see that we actually have quite nice bone that's regenerated in terms of width. So definitely not too bad, even though it exposed and was infected, it didn't destroy the majority of the bone graft. And that's why I like to try to nurse it along at least a little bit if you can, especially if you have a late exposure, because then you know that some of the bone has already formed and healed. And so I just took out the membrane and closed it up because you can see that the tissue quality is not very good. And so if we were going to do an implant or do anything at this point, then that certainly would be a problem. And so just let it heal and then come back to place the implants. So then the patient comes back, and you can see that the healing is okay, but the tissue still was not great. And so we waited a bit longer for the healing, and then we were going to do the implants. And so there was a big discussion here. What is the treatment plan going to be? Certainly, we can either do one implant with a cantilever or we can do two implants. And the discussion with the prosthodontist that I was working with was that there really, really wasn't space to do two implants and have enough bone or space in between and have them in the position where they would like to be. So we decided to do one implant in the canine position and then cantilever to the lateral. So obviously, it's going to be more favorable to cantilever to the smaller tooth and cantilever anteriorly instead of posteriorly. And so that was what was decided as going forward here. This is the implant being placed, and you can see that we have very nice bone on the buccal, and then the lateral incisor is going to be cantilevered. And so we can see here a surgical index was done at the time. So then at stage 2, it could be uncovered and a temporary could be delivered. And of course, this could be done in different ways where a fully guided procedure could be performed and a temporary or the final restoration could already be made at one time, whether you're going to use a Zento or a Simplant or any other kind of planning software and procedure to do that. This could definitely be done. And so then you can see that a little bit more grafting at the time of the implant. And like I said, we always reserve the right to graft more, but sometimes when you try to do too many things, you can get yourself into a little bit of trouble, which obviously is the case. So is why I'm showing you this case. So you can see here, I wanted to try to really have a lot of maintenance of the soft tissue and really maintaining and stabilizing the contour. So that's why I did a GBR at the time of the implant placement. You can see the collagen membrane here and then closure. And you can see again, the quality of the tissue is just really not very good. And so again, in retrospect, I probably should not have done so much grafting because I knew even though I was able to release the tissue and get primary closure, the quality is compromised. And so is it going to open a little bit? And that's always the question. And so, of course, it did. Not too bad, but it did open. And she wasn't a really great person with hygiene, and so getting her to really swab and take care of keeping it clean was a little bit challenging. And so that's really, again, what I wanted it to do. This is after about 3 weeks, and you can see that we have the cover screw showing through here. And so again, swabbing it with some chlorhexidine and keeping it as clean as possible. And then you can see here, opening the area at the time. And I wanted to do a little bit more augmentation again, because it's a young person and had a lot of tissue that was missing. And so, this is where you start to think about how much is too much, and the enemy of good is better. And so, really a time where thinking about cutting our losses and not continuing with more and more surgery is something that you always think about, but you always want to make it better. And sometimes you are even a little bit more critical than the patient is. And she was actually just wanted a tooth that was not removable. And so, thinking about the patient's wishes versus your own is always something to consider. So this is what she ended up with her final. You can see here we have a nice color match. Everything looks good, but certainly we have a vertical problem still that we knew we were going to have. But again, we've maintained the papilla nicely on the adjacent tooth and the adjacent premolar back here, and a decent result with pink porcelain. But again, I think that this probably could have been done in a little bit less surgery and without some of these complications if we had paid a little more attention to the soft tissue at the time. So let's talk about some long-term complications. I'm going to finish up with a couple of these cases. This is what happens when implants are placed too far to the buccal, or there isn't enough buccal bone on that buccal aspect of the implant. And, we previously used to think that you only needed a millimeter of bone all around an implant, but we know now in the anterior maxilla, 2 and even 3 millimeters is ideal and what you have to have. And so if not over the long term, especially in patients that are going to need to have these implants for 30, 40, 50 years, this was a 16-year-old when no 18-year-old when I did this implant, and then now when she returned to me it was 10 years later. And so the implant was placed to buccal, and we have a dehiscence in this area here. Her papillas have held up very well, but the buccal margin is not good. And so we know that if we have a situation like this, we're going to need to graft quite a bit. And does the soft tissue envelope allow itself to be stretched and moved and mobilized in that way? And is it not only the quantity that can do that, but the quality as well? And so sometimes thinking about either doing a soft tissue graft at the time or even before the procedure is a way to think about these procedures now. And so obviously we don't want this to happen where we have the implants that are completely dehisced after a GBR procedure. And this is a case I'll show you in a second. So this is a patient, a 61-year-old male who needs full arch rehabilitation immediately, of course. And, even though we discuss and we tell the patients if you're going to have an immediate full arch reconstruction that's going to be loaded at least with the teeth for aesthetics, they're not there to be functioned on. You absolutely have to be on a liquid diet and not chew at all. And of course, sometimes the patients don't listen. So obviously that's what I'm going to show you. So this was his mouth beforehand. You can see here, not in very good shape. A lot of discussions went on about, keeping certain teeth, not keeping them, and it was decided that he was going to be edentulated. This was all done guided, fully guided, with intraoral scans and CT scans. Teeth were extracted. I'm only going to show you the maxilla here because that's where the complication occurred. You can see the implants were placed, no problem. He did very, very well afterwards, and this is his restoration. And one of the things that I always say is if we're talking about doing a full arch case, we don't have to load all the implants with the temporary restoration. If the implants are not stable enough, they can absolutely be buried. And then when you come back and uncover them, then they can be utilized in the final prosthesis. So that was the plan here. Now, of course, the patient went home and he chewed because he felt great. He said he gave it about a week without chewing, and then he started to eat. And of course, again, he lived far, and he was very busy with work and never wanted to come in. And so he definitely chewed on all of these, and so started to have a loosening of the prosthesis. So this was his initial delivery. I'll show you everything went very well. He did great, but when he came back, he had a huge amount of bone loss, major defects, lost multiple implants, a massive failure. Okay. And you can see the other side as well. So what did we have to do? We had to do a guided bone regeneration to try to salvage some of the implants that were stable, and then remove the implants and start over. And so the thought of doing all this, now you know how I said if you need to do a little bit more grafting, then maybe you don't charge the patient. Well, when the patient is not compliant with your very explicit instructions, then they have to pay for sure. They don't get any of that for free. So he obviously had to bear the costs of the guided bone regeneration procedure. And here I wanted to add bone, but I also wanted to improve the soft tissue. So this is the Volumex that actually can really help regenerate both hard and soft tissue. And so you can see here that this is working as a membrane for our GBR and also helping to improve the quality of the soft tissue. You know, most of the time our defects are both hard and soft tissue. And so starting to think about and starting to have materials that can answer some of those questions and address both areas is very helpful. And so you can see here that everything was closed primarily. He had to go back to wearing a removable prosthesis. So he was wearing a denture. Asked him to not wear it for a couple of weeks. He refused. And so I told him that, you know, if he wears his denture quite a bit, then there is going to be a problem potentially, and he could have failures of the graft as well. And so this is the additional implants that we had to place. We had to remove, or the implants were lost. We had to graft this whole area and then place new implants posteriorly. So this is after everything healed. He ended up healing very nicely, followed some more of the instructions, definitely better than the previous time. Everything healed very nicely. You can see all his implants are now integrated. The mandible already was fine the whole time because the bone quality was so much better. And then you can see him. This is all of the tissue, the soft tissue. This is the area where we augmented some of the soft tissue as well. And you can see here that he's in the process of having his final prosthesis, where a bone grafting procedure had to be done after the fact, after everything had failed. So I think this is one of the last cases that I wanted to show you. A patient, you see that I didn't really notice this when I was putting this together, but it seems as though the patients where the complications occurred were the ones that don't live near you. And so maybe that's really the rule. And I should put that in my risk assessment: geography. If they don't live close to you and they can't come back for their visits, then it's something maybe we should really consider and think about not treating them, or treating them a little bit differently. So she previously had failed implants in the anterior maxilla. Money is no obstacle. And of course, when that's the case, sometimes you might think that's a good thing, but sometimes it's not a good thing, because then they're going to really expect perfection. And sometimes we can't deliver. And of course, as I said, she only lives in California in the wintertime. And so this is how she presented. And so she's been missing these teeth and has had failed implants. And so CT scan was evaluated. I don't have that here in the interest of time, but she had adequate bone to place the implants, but not to do not. But we also needed to do guided bone regeneration at the same time. And you know, in retrospect, again, I think that maybe doing a GBR procedure first and having her come back after might have been a better way to go. However, because of where she lived and that she wasn't going to be here until the following year, then I decided to do these both at the same time. And so, again, this is probably a poor judgment in terms of selecting the procedure and trying to do too many things at once. But you'll see when I open the area, the implants are in good bone. There's no dehiscence of the implants, and we have adequate bone for placement. So, on one hand, and we have good spacing between, we're a good distance from the adjacent teeth. And so I was very comfortable with doing this procedure with a GBR at the same time. And you can see here, obviously, I'm showing you complications when they occur, but I have hundreds of times when this is very effective and successful. And so you can see here, this is our guided bone regeneration procedure, utilizing a membrane. And I also used this is a perioderm to help with soft tissue thickness as well at the time. So she needed a bit more soft tissue. And so I did that also at the same time, which is different than in most of the previous cases. And so you can see here, primary closure, really no problem with closure, not even under any tension at all. I didn't have to do a significant periosteal release. She was okay not wearing any kind of prosthesis here, so I was confident that that she was going to heal well without that, especially since there was no pressure. So then she comes back a couple weeks later, and you can see this is, I think, about 10 days later, and you can see that we're having some dehiscence here again. And, sutures are intact here. This area in the vestibule looks good, but right at the area where the majority of the tension is, she started to open. And so she ended up, this is after about 2.5 months. And you can see here that we start to have some of the implant that's visible. We have a little bit of inflammation, maybe even a little bit of purulence. She was keeping the area fairly clean, but not perfect for sure. So then at the time when after everything had healed, I nursed it along for a while and it just did not heal. And so I said, I need to open this and see what's going on. The last thing I wanted her to do was to go back to Canada and come back, 6 months later and then have this problem that's a major infection. So you can see once I opened everything, we have just a complete dehiscence of the implants. And so certainly not something that we could try to graft or try to salvage. And so these were going to need to be removed. And, when you've made a decision like that, I really think it's always better to remove them sooner rather than later. We never really identified a reason why her initial implants failed. And, giving it another try is always okay and acceptable. But when somebody has failed twice like this, then that's something really to think about. Is she a great candidate for implants at all? And why are these grafts and these implants not taking in an otherwise seemingly healthy patient without any medical problems or smoker or anything like that? And so, of course, when you take out the implants, it's a very, very large defect, and so we're going to need to decide what the next step is. And so you can see I just closed it up. I said, we're not going to try to graft again. You didn't do well with any of the grafts that I did or, the previous person had done that tried to do these implants. And so certainly not ideal. And you can even see, even after just removing it and closing the tissue, she still did not heal very well. This is after about 2 weeks. And you can see just the terrible wound here. And so she's fed up with implants and she doesn't want to have any more grafting. Maybe these are patients that might have some type of sensitivity to titanium implants. And maybe this is a case where I should have thought about doing zirconia implants. And I actually have some other cases where that's the case when someone's come with a failed implant that we can't identify a reason for. Maybe there was some type of sensitivity to the titanium. And when I've done zirconia implants on them, then they've done very well. And so something to keep in the back of our mind that, not everybody is going to be a perfect traditional implant candidate. And so what's our backup plan here? And so, a lot of discussion about implants and other types of procedures. And she said, you know what, is there any way I can go without implants? Can I just have a bridge? And so that was what was decided. And so this is her final restoration. This is her bridge in the anterior. And from far it actually looks pretty good. This is not a bad result. She's pretty happy. When you see it up close, though, I'm not super happy with how this was done. I think we could have done things a little bit differently. This is the defect she has, so it's a pretty big defect. Right now, we have vertical and horizontal. I've left her worse than how she came to me, and so you can see that this is certainly a problem. And we've compromised this canine a bit as well. Fortunately, the central is still in pretty good shape, and the rest. I mean, she does have recession on a lot of her other teeth as well, but this is probably from toothbrush abrasion, but definitely this is from all the scarring and the pulling. You can see the very tight frenum even here. And so this is her prosthesis. Now, while I like this aspect very, very much, the bridge goes all the way to the canine over here. I think that this is not ideal. It's really she doesn't have a high smile line and her lip is very thin. But if this were on an implant, you could always put acrylic or porcelain here. But this long tooth just is really not very aesthetic. But when she smiles, you can't really tell. And she was happy just to have something fixed and be done with treatment. And so I want to leave you with a few take home points. for today. Number one, guided bone regeneration is predictable in general. Okay, now, of course, I showed you the worst cases. And, in being in an academic institution, I get sometimes the worst of the worst. People have had multiple failures. People are very, very compromised and, and stuff. So we all have those patients. But knowing that GBR is predictable, but complications can occur. And so not to get frustrated with yourself. And obviously we do everything we can to prevent these complications, but they can still happen. Many techniques are described, each with their own indications and materials as well. What are we going to use? When are we going to use it? And I still think that, there are room for improvement with materials, maybe materials that resist the compression, maybe membranes that are a little bit easier to use and might not have to be tacked down or screwed down, maybe things that can both augment soft and hard tissue together. So those are some of the kind of technique and material improvement that I think that we can discuss and continue to innovate. Surgical complications can both be short and long term, so super important to make sure that the patients are aware and we identify anything that's happening so that we can follow it along and see it to its resolution. Most common complications are going to be membrane exposure and infection, and usually these are going to come either if you're using a titanium reinforced or membrane or mesh that gets exposed, or if your wound dehisces, even if it's a traditional membrane. And then primary closure without tension is the key. And so if your soft tissue envelope is not ideal, or if there's infection there, maybe you want to let the infection subside. Maybe you want to consider augmenting the soft tissue first, or reinforcing the soft tissue at the time of bone graft or implant placement. Because certainly if you don't have primary closure, or if it's under tension, it's going to open and it's going to be pretty significant. And then have a backup plan in case complications occur. And one thing I should have put here, but I think we talked about it a lot, is your temporary prosthesis. What is that going to be? And discussing it from the beginning before you embark, not after you're done with the procedure. Oh, by the way, you can't wear your denture or your flipper for 2 months or 2 weeks or whatever. The patient has to be on board with that. And so maybe, the patient decides at a certain time they want to do the procedure when they can go around without the temporary in, or with the mask or what have you. So obviously those things are going to be really, really important. So I encourage us to really focus on that temporary prosthesis and make sure that we can all agree on how it should be. So with that, I'm going to stop sharing my screen and I will take any questions that you all have. And so we're going to give you a minute to scan this QR code.
Just a second before that. So as you said, so first of all, thank you so very much, Doctor, for a great session, very informative, very interesting. So thank you so very much for that. There are many questions waiting in the Q&A for you, but before we'll get there, I would like to ask everybody here to fill out the session survey, which can be accessed either by scanning the QR code on screen, just like you said, or using the link in the chat pane. It takes only 2 minutes to fill it out, and we really need it for future improvements. And of course, your opinion is highly important, and we really appreciate that. For you as clinicians, at the end of the survey, there's the link for the CE quiz as well. I would also like to inform everybody of our next events. So on April 23rd, Professor Bozic will be here for 2 sessions. So on April 23rd, he will be here for a live surgery. And on April 28th, Professor Bozic will have a webinar which will discuss about taking volume to the maximum, the use of sugar cross-linked volumizing collagen scaffold as less invasive option for soft tissue enhancement. On May 4th, Dr. Peter Randall-Sofer will be back for a 3rd session in his series to discuss about enhancement of the peri-implant tissue towards a biologically oriented aesthetic restoration at the smile zone. To review the entire list of events, you are all more than welcome to go to enter the Datum Dental website. All the events are there detailed. You can also register from this page as well. So as promised, Dr. Agolo, let's go over the questions as asked by the audience.
Perfect. We have a lot of really great questions. So thank you all for that. Very, very good ones. Ones that I was thinking about myself. Okay, so let's start with the first one. So, wouldn't HA's non-resorptive property make it less than ideal in a future implant site, like in the anterior mandible case? So, that's a good question. So, if I'm using any HA, it's porous HA or it's HA TCP. And as you saw, the either the porous HA or the HA TCP does resorb enough to nicely incorporate the graft, and then it maintains some of the volume. It's sort of the same as what a xenograft does, where you have the particles that do integrate, but it also remains to help support the soft tissues. And so, like I said, it's, the HATCP or porous HA is not perfect and ideal, and certainly we would like to get to an alloplast or a synthetic that we could potentially use so that we don't have to use a xenograft or an allograft or an autograft, but we really just don't have that yet, unfortunately. And so you are going to have a compromise, which kind of brings me to the next question that somebody asked is, what bone recipe do you like to use? And that is an excellent question. Um, so it really depends on what type of defect. If I am grafting a socket, then I'm either going to use a mineralized allograft, or I'm going to use like an Ossex bone, which is the collagen cross-linked material. So when you have nice walls, you don't have to have a whole lot of structure, but you want something that's going to resorb basically by the time you get back to the area. So if I am doing a sinus augmentation, which somebody asked about here, um, you can utilize some autogenous bone to help speed up the remodeling of some of the graft materials that don't remodel very quickly. So, for example, if you're using a xenograft in your sinus grafts and you're waiting 9 or 12 months, if you add some autogenous bone to that, it will help things remodel and turn over faster. And so I do think that that those combinations are very helpful. Now, what percentage is tricky? Generally, I want it to be. It really depends. I want generally a 50% something that's going to resorb quickly and 50% something that's going to resorb slowly. And so if you're using a xenograft and an allograft, or a xenograft and an autograft, then you would do a 50-50. Now, when I'm doing a larger defect or something where I do want some of the osteoinductive and osteogenic properties of an autogenous graft, I will do something that somebody asked about here, which is using a bone scraper and scraping some of the bone from either the local site where we're working or from an adjacent site. So I think that is a great way to be able to enhance your grafting properties by using some autograft without actually having to take a block from the ramus or something like that. So if you're working in the anterior maxilla, you can go higher or more lateral than where you are, and you can get some nice scrapings. If you're doing a sinus augmentation, I usually use the scraper to scrape the window, and that's one of the ways that I do that by utilizing the scrapings on the window to use for the autogenous bone graft. So a lot of those options are there, which really help to add the autogenous bone without having to get a second site. One person asked about diabetics and patients being under better control prior to surgery. So, there is a very nice study that looks at implants and control by hemoglobin A1C, and that number is about 8.1. And so that's the number that I use. So if somebody is higher than 8, then implant failure has been shown to be increased. And so I would also not do a bone grafting procedure anyone higher than that. Now, of course, we like them to be 7, 7.5. So really anywhere between 7.5 and 8, I think is a good cutoff for you to utilize when you're thinking about bone grafting or really implants as well. And then the question of nobody's asked this, but I think it's also important, is what should we be using antibiotics? And if somebody is immunocompromised in any way, such as a diabetic or someone who's on steroids or any other kind of immunosuppressant medication, I always use antibiotics. And if I'm going to use antibiotics, I want to have a pre-op dose on board, whether they take 2 grams of amoxicillin orally, or if I'm sedating them and I use ampicillin or clindamycin or whatever in the IV, but I definitely want to use the antibiotics pre-op, okay? So you want to have a blood level of the antibiotics in on board before you start your procedure. Of course, you'd give them post-op antibiotics as well with a bone graft, but if you want antibiotics, you really should be giving them before. So I use the consultation appointment and to discuss, and you know what medical problems they have, and then you can give them the prescription, or you can electronically prescribe it, or whatever you want to do. Um, Question about the tack down membranes. So about the temporary prosthesis over the surgical site. So if you're doing a large GBR on the buckle and you have it tacked down and you have a prosthesis, if there's any way to make it tooth borne, I would really, really want to try to do that. Um, if you have to use some kind of flipper or removable device, you want to absolutely cut down that surface that doesn't, so it won't touch the mucosa. And one thing that I kind of use to maybe trick your patients a little bit is, let's say you're going to use a flipper and it's going to replace 1 or 2 anterior teeth, and it has some gingiva on it, pink acrylic gingiva. Either you can take all of it down and make it so it's a tiny little nub, and then they wear that, or you can tell them, hey, why don't you not wear this for 2 weeks or at least a week? Let the swelling all go down and then come back in and I'll adjust it. And then I don't have to adjust it as much because the swelling's already gone down. Because once you take off all of that prosthesis, it's a lot harder to put it back. And so I definitely think that if you can get them by any means necessary to not wear it for the first couple weeks, then it's going to be very beneficial. At least the initial soft tissue will heal. Maybe you'd still have potential pressure on the graft and the mobility, but your soft tissue would already be healed if they're not going to wear that. And you can't always trust the patient, so maybe you keep the prosthesis in your office and then you give it back to them when they come back, because you certainly don't want them to try to put it in at home when it's not adjusted. So that's what I would say to that. There's a question here about a second CBCT after a 2-stage treatment. That's a great question. And a lot of times people are taking a lot more CBCTs now because they have them in their office, and maybe you're not charging the patient, maybe you're charging them minimal. And I think that it's always important to make sure that we're not taking too many scans only when you really need them, because it is radiation. And while it's not a lot of radiation, it is still radiation. So for example, if you were going to do a GBR procedure, you generally want to have a scan beforehand, especially if there are going to be anatomic features that you're concerned about, or if you're thinking that you might want to be able to do the implant and do the bone graft at the same time. Or, of course, if you're going to do guided surgery, then you have to have a scan. After the graft, unless you're going to do guided surgery, I don't know. I mean, yes, you can get a new CT scan if it's a large graft, but if it's a small graft and you are going to do the implants anyway, and you have your guide that's not computer generated, then you may not need a secondary scan. It really depends. We don't have our own scanner. Everything has to go through radiology, so the patients have to pay a lot. And so if I don't absolutely need one, I don't always have them get a second scan because they don't want to spend the money. And we have a lot of patients that are very radiation risk averse, and rightly so. I think that we do a lot of scans that may not be perfectly necessary. But if you have an absolute reason that you need the scan, then I think it's absolutely fine to do it between the GBR and the implant procedure. And how much time should you wait? That really depends on the graft material you're using. If you're using a pure autogenous bone graft, like I showed you in the first case, whether it's a block or an autogenous only particulate, or even a mineralized allograft particulate, you want to go in about 4 months, really no more than 5, because you're going to start to have resorption of the bone. If you're using a xenograft or something with HA that's going to take longer, then you're often going to have to wait longer. So if you're using a xenograft, you have to wait 9 to 12 months. If you're combining a xenograft and an autograft, or you're mixing it, then you can often go in at about 6 months. So I generally am going in between 4 and 6. So probably 5, sometimes 4. So 4 to 6 months is really the time I like to. The patients get very antsy, and it's very, very hard for them to wait much longer than that. So I'm usually utilizing materials that are going to resorb in that time. And so that's the what I use. Um, so when people are asking about what can be done so that a patient will not thrust the tongue into the GBR area in maxillary case, that's a really great question. Um, if they have a tongue thrust habit, that's pretty challenging. If they already have that and you know that, maybe you could you could have a prosthesis or a type of appliance made that can sit on the mandible that can help position the tongue so that they won't do that. Um, you want your sutures, though, also to stay around a little longer. So you saw in most of the cases I'm using Vicryl if I'm using something resorbable, or if I ever use anything that's non-resorbable, it's going to be nylon or Prolene or maybe PTFE. Those are a little expensive, and I haven't found that they're significantly more successful or relieving of tension than nylon or Prolene. So I generally am using those. So I think that if you can use something that's going to stay around longer and help take some of the tension off, then that's what I would do because it's a little bit difficult. We have a question here about infections. Do have I seen more or less infections after sinus lift procedures during the COVID pandemic? It's a really good question. I haven't noticed more infections after a sinus graft procedure, but it could also be that we're not doing as many since COVID. So, and these days I don't do as many because we're often using shorter implants or, on these big GBR on these big full arch cases, we're usually tilting the implant. So, I haven't seen more. What I have seen a problem with is patients that are allergic to penicillin. Especially because I don't think that clindamycin is as effective, and so I'm not a big fan of clindamycin to be honest. So we did a study that we never published, but we presented at a couple of AO meetings that. Patients who have an allergy to penicillin have potentially more complications after bone grafting procedures, especially sinus augmentation. And if we gave them clindamycin for an infection, they didn't really recover from their infection as quickly until we changed it to something stronger like Levaquin or azithromycin or one of those other antibiotics. And so clindamycin is really not as effective as penicillin or some of these more broad antibiotics. So that's when I have noticed a difference. So one of the questions is, according to Urban, once exposure takes place, the membrane should be removed in 6 weeks. But in my experience, you showed that if you nurse it along, the area does give good results. I have to agree with that. I think if the patients are able to really maintain and keep it very clean, obviously they're on antibiotics and they're doing some local wound care, then I feel that you can leave it longer. And the longer you can leave it, obviously if there's a major infection you absolutely have to take it out. But if not, then if you can maintain it, then you can salvage a lot more of the bone graft, and so I definitely do that. There's a question here about particle size. Do I recommend grafting with smaller or larger particles? And it really depends because if a material has pores, then the granules or particles can be larger because you have the pores. If you have materials that are large, sometimes they're harder to get into the smaller spaces. So if you have a huge defect, then obviously it's easier to use larger particles. But if you have a smaller defect or a lot of little nooks and crannies and holes, then you want smaller particles. I think probably the ideal that I utilize is between 250 and 750 microns. I don't really go larger than 1,000 microns or 1 millimeter, to be honest. So I really like the 250 to 750 range. So there's a question here about the flap. And I think that flap questions are great because when you're doing a large bone graft, you really want your incision margins, your vertical release to be away from the defect. We spent a lot of time in the past, and I was definitely one that was guilty of this, trying to do papilla sparing incisions. And the problem with that is that you often end up leaving such a small cuff of tissue around the tooth that when you suture to it, you kind of put a little tension on that and it pulls the papilla away or it pulls away from the gingival margin. So you can put papilla back very, very nicely if you use good sutures. And if you need to, and if there is if you're trying to put some occlusal tension on it, you can always do a sling suture or you can pass the suture over the contact point or occlusal to the contact point and tie that down and keep that for, a week or so to help put some tension in the occlusal direction. So I'm really a little bit more of a fan of not doing papilla sparing these days, unless you're going to leave a pretty big cuff away from the margin of the gingiva, to be honest. So, and I think that having your verticals more away from where you're doing your grafting is better. So it allows you to get your membrane nicely in there. It gives you the ability to release the tissue. If you have a very small flap and you're going to do a periosteal release, then you're often going to compromise that flap. And there's nothing worse than compromising the flap and then having it where it's going to dehiss somewhere in the middle. And that's almost impossible to fix. So I really think that that's important to consider and think about. Um, One question here about how long do we wait if we do implants with GBR? Again, it's the same. So if you were using materials that had a lot of xenograft, you may want to wait more like 6 months or even longer before you uncover the implants and put your restoration there. So similar again, depending on what type of grafting material you're using. So really mostly related to the graft material. Let me see what other questions. Here we have a question about smoking and alcohol. How long do you recommend your patients stopping smoking and using alcohol before and after GBR? So the studies have shown that it takes about a week for the tissues to completely go back to normal. So I generally will use a week for stopping smoking. It kind of depends because if you look at anesthesia studies, then the for smoking, if you're going to put someone under anesthesia, usually for most of these cases the patients are sedated. And so in my practice, so if someone is sedated, I really want them to not smoke for about 2 weeks. And so, but you can't always get them to do that. And so if you have to compromise, I would say a week. And then of course you want them not to smoke after for at least 2 weeks, maybe even 3. And if they're not smoking for 2 weeks before the surgery and 3 weeks after the surgery, that's already 5 weeks of non-smoking. So they might as well quit. And I tell them, you might as well quit if you're going to do that. So, you can, depending on what kind of relationship you have with your patient and what kind of patient they are, you can request to them that they quit. And, I often use the analogy of maintenance of implants. I say, you're going to have to maintain your implants and it gets very expensive. And this procedure is expensive. And how much money did you spend last year on cigarettes or alcohol or what have you? And so if you can take that money, especially cigarettes, I mean, people aren't going to quit drinking and that's another story, but smoking, if they're going to not smoke, they'll have quite a lot of money left over to, do implant maintenance or pay for part of this procedure or whatever. And so if you kind of approach it from the wallet, sometimes it can be a little bit effective. And if you're thinking about that. So that's really what I have to say. That's most of the questions answered. We've gone a little bit over time, Chen, so I'm sorry about that. I hope that was okay and people
It was
didn't
great.
didn't have other things that they had to get to. But I really appreciate everybody being here. We had really great questions, and I hope everybody learned something. And hopefully, I'll see you all again in another webinar or live session.
All right. And with that, I would like to thank you, Dr. Agalu, for your time, efforts, and professional input. And thank you, everybody, for joining us. And I hope to see you all in our next events. Thank you, everybody, and have a great day.
Thank you. Bye.